Okay, good afternoon. I'm going to continue to watch the waiting room and we'll let people in, but we're at the top of the hour and I know everyone's really busy. I'd like to get to our presenter. So thank you for joining us. This is our first presentation of the academic year, and it is part of the West Virginia University Center for Excellence in Disabilities, our Ability Grand Round. So this is about the fourth year we've been doing this, and our speaker, Dr. Landis, is a returning speaker. So it's wonderful that um, he's interested enough to come back and talk to us, and we just can't get enough of his work. So really quickly, before we get to that, on the slides, just a little bit of a background. The idea of the Grand Rounds is to hear from peers like Dr. Landis and other. So we have statewide, national, and international perspectives. The common denominator is that it is research or scholarly work that's focused on disability services, supports in some way. It can vary on the age group, it can vary on the type of disability, but the common thread is that it's scholarly work on issues that pertain to individuals with disabilities of some sort. Closed captioning is provided. Please use Zoom to request. If you're not sure how to request that in the Zoom functions, shoot me something, a little message in the chat. I'm happy to follow up on that. And certificates of attendance are available. Let me know that too as well in the chat if you would like one of those. Before we get started, if you haven't already, we're all Zoom experts here. Please mute your line. We do, however, like interaction and comments and questions, suggestions, things of that sort. Feel free to use chat during the presentation. We will include some time for sure to ask questions and about Dr. Landis's research and otherwise. So please feel comfortable engaging. We'd love to hear it. Prior to that, let us know who you are. Share your name and affiliation in the chat. Use your camera if you're comfortable doing that. That's part of that Zoom community. If not, we totally understand. And then if you have something that you want to say and interject, please use the raise your hand or again, the chat piece. So use some Zoom etiquette. I will share the evaluation piece again closer to the end, but if you're wanting that, the Zoom or the link, Qualtrics link is here. I will put it in the chat later. Again, this gives us feedback to continue to strengthen our sessions over time. So with that, let me stop sharing and introduce our speaker. So Dr. Scott Landis is an associate professor of sociology and a faculty associate in the Aging Studies Institute at Syracuse University. He received his PhD in sociology from the University of Florida in 2014. And he likes to focus on data. So you've all seen the title and you've seen the objectives, and I'm very excited to see what he gets at the crux of the measurement of disability today. So we're going to learn a little bit more about his approach. With that, Dr. Landis, I'll turn it over to you to get started and share your slides when you're ready.
Great. Thank you, Leslie, and thank you for the invitation to be here with you all today. Let me get the slides going. All right, you got my slides?
Yes, we can see them. Thank you.
Great. All right, so we're going to talk about disability measurement. Let me get this out of the way for myself. Okay. I'm Scott, Leslie already said I'm Scott Landis. I'm at Syracuse University. And I got into working on disability measurement inadvertently. Most of what I do, and it's what I presented on last time I was with you all, is mortality research. So trying to understand mortality patterns, age at death, cause of death. Initially for people just with and without intellectual and developmental disability, but has subsequently expanded to consider disability in general. And if you're interested in that topic, I've just got a paper that just came out in Health Affairs. I can send you kind of looking at mortality patterns from 2008 to 2019 in the US for adults with disability. But it's through this research that on mortality that I came to kind of pick up this secondary line, looking at the way we measure disability in national federal surveys, nationally representative surveys. And specifically because of a big change that was made back in 2019. So let me give you some background. So since 2008, what's commonly known as the ACS 6 questions, the American Community Survey questions, were fielded in the American Community Survey, which is from the Census Bureau. So this is the survey that the Census Bureau runs every year in between our decennial censuses. And so this is a nationally representative sample of the US population where they collect data, ACS data every year, and it allows communities to track what's going on as far as the population. And I think any of you who use the ACS data, the American Community Survey data, know that the real benefit of this survey is that you can drill down to the county level via zip code. And so this data is used not only by the federal government, but by also a lot of local governments in order to try to understand population dynamics. And so specifically around disability, a lot of rural communities will use this data to try to estimate the percentage of disabled people living within their community, and therefore decide appropriations for funding for transportation, for related services. And larger communities will use it as well to try to get an understanding of the distribution of the disability population within their communities. And so there's a real history of using this data in order to guide policy within the US, allocation of resources and down to the local level. So since 2008, these are the 6 questions that the American Community Survey included in its disability segment. And so whether you have hearing difficulty, vision difficulty, and this is the wording blind, or having serious difficulty seeing even when wearing glasses, cognitive difficulty. And so this is a catch-all because of physical, mental, or emotional problem, having difficulty remembering, concentrating, or making decisions. I mean, the real question, and we could get to this in the Q&A, is who's being captured here? I mean, this could be people with intellectual and developmental disability, but also could be someone with Alzheimer's or traumatic brain injury. So you can't differentiate the cognitive limitation that's actually being posed here. Ambulatory or mobility difficulty, walking or climbing stairs, self-care, bathing or dressing, and independent activities of daily living. So errands, visiting a doctor, things like that. And so, like I said, since 2008, the American Community Survey fielded this. And these 6 questions were set as the standard for disability data collection by Health and Human Services. So this is a 2011 document, which is their implementation for measuring, HHS put this out for measuring race, ethnicity, sex, primary language, and disability status. What's interesting about this document, and I personally agree with this, is they're making disability status a demographic characteristic. So moving away from seeing it as a medical issue and saying that this is a demographic characteristic of the individual and that we should be collecting disability status anytime we collect race, ethnicity, gender, sex, or primary language. And so what HHS said, this is actually in response to the Affordable Care Act. The director of HHS was required to set the standard for measuring these demographics per section 4302. And so what HHS said in 2011 is that the ACS 6 questions, the one that I just showed you, are actually the standard. They're the ones that should be used in all federal surveys in the US. So then it was a bit of a surprise in 2019 when the National Center for Health Statistics changed the disability questions that they used, both in the National Health Interview Survey, the NHIS, and NHANES, the National Health and Nutrition Examination Survey. And so both of these surveys are fielded by the National Center for Health Statistics. And they briefly announced this change, but really did not give any justification for doing so. At the same time, for those of you who are specifically interested in intellectual disability, in 2019, the NHIS and the NHANES dropped their questions for intellectual disability. So from 1986 through 2018, there were distinct questions about whether someone self-reported having an intellectual disability in both of these surveys. And with their switch from the ACS-6 to the Washington Group questions, they dropped those intellectual disability questions as well. So let me show you the Washington Group questions, and you'll be able to see how they're a little bit different from the ACS-6. They ask some similar functional limitations. So you have vision, hearing, mobility. These are the similar ones, cognition, self-care. But then instead of independent activities of daily living, the Washington Group questions ask about communication. Using your usual language, you have difficulty communicating or being understood. The real difference between the two, though, is whereas the ACS-6 questions, the ones that I showed you earlier for vision, hearing, cognition, mobility, self-care, and IADLs, are yes/no questions. And so it asks the respondent, do you have difficulty hearing, yes or no? As you'll see, what the Washington Group questions do is they ask you to rate your difficulty. Would you say you have no difficulty, some difficulty, a lot of difficulty, or you cannot do it at all? And so for each one of these functional limitations, the respondent has to pick one of these categories. And this really is where the concern comes in. And this is, the Washington Group questions are, the Washington Group was formed by the United Nations Working Group back in 2004. And the purpose of the working group was to develop disability questions that could be used internationally so that we could begin having comparisons across countries, and specifically targeting countries that did not do any disability data collection in surveys. And so their job was really to push countries to begin collecting information on disability, something that we already did here in the US, but a lot of other countries did not. And they've done a really good job of pushing this agenda across the globe and getting other countries to begin developing information, developing data collections on disability. The challenge is for a couple of different reasons with that scale that they use, especially because the categories are no difficulty, some difficulty, a lot of difficulty, or cannot do it all. And that some difficulty response has been problematic. And it's not just here in the US, but across the world, where respondents don't know what some difficulty means. It's a really interesting decision they made, that instead of saying no difficulty, a little difficulty, a lot of difficulty, cannot do it all, that they changed that to some. And that translationally into other languages becomes difficult, but even when translated correctly, people just don't know what is meant by some. The second challenge with that scale, and this is a tricky thing, because if you hear folks from the Washington Group talk about it, they'll say, oh, this is really beneficial because we have a scale that can be used, and so that you can get an idea of level of functional limitation the person has. But what they do is they dichotomize the scale. And so if you look into the Washington Group literature, they'll tell you that there's a cut point, and that what you should do when you have the data is you should only count people who report they have a lot of difficulty or cannot do it all as disabled. And that anybody that responds no difficulty or some difficulty is non-disabled. That's what the Washington Group literature states you should do. However, their proponents have advertised, well, that's what you should do, but you can actually do whatever you want. And so if you have the data, what they really advertise commonly now is that you can make the disability cut point wherever you want it to be on the scale, which is something that I know myself and others have pushed back on, because what you've done there is you've switched not only questions, you switch from using questions that are pretty readily recognizable by the respondent. The respondent can say, okay, I'm being asked whether I have trouble difficulty. That's what I've got, is a vision disability. Okay, so the ACS 6 questions, it's obvious. You're asking me, do I have a vision disability? I'm going to tell you yes, that I do. If I'm to respond to the Washington group questions and they ask me if I have trouble difficulty seeing, I have no idea, where's the disability mark? Is it at some difficulty? Is it a lot? Is it cannot do it all? And so the challenge becomes that the respondent, content validity, the respondent doesn't know what they're being asked or where the cut point is. And then the owners of the data, in this case, the federal government, they have the freedom to say, well, we're just going to make the cut point wherever we want. Yes, we could make it more broad and include anybody with some difficulty, a lot of difficulty, or cannot do it all. But we also can make it more narrow in situations that we want to, where we can say, okay, the only disabled people are those who state they cannot do something at all. These cut points matter. And so, like within the Washington group questions, if you say, okay, disabled people are only those who cannot do it all, well, you're saying that the disability population is only 2%. If you say disabled people are those who cannot do, have a lot of difficulty or cannot do it all, you've bumped it up to about 10%. But if you say that the disabled population is people who report some difficulty, a lot of difficulty, or cannot do it all, now you've bumped it up to 32%. So where you put that cut point, which is what they advertise is variable and up in the air, really matters. Okay, so what happened that really got people very upset, including myself, is in October of this past year, the Census Bureau announced that they too would be changing from using the ACS 6 questions to the Washington group questions. And their plan was to do this next year in the 2025 ACS 6. By their own admission, this change would undercount the disabled population by 42% or 20 million people. And so simply by changing from the ACS 6 questions to the Washington group questions, you'd wipe out 20 million people being reported as disabled. These are people who are disabled, but would not be reported as such within the American Community Survey. So this matters. So if you go back to, I've got a friend in rural Montana that he and his center use the ACS data to help rural communities and counties in Montana estimate types of services they need, the funding they need for disability services across the state. It would take two things. Number one, the shift in questions is a 5-year lag time before counties can catch up and understand what's really going on. But what you would really do is those counties would know that we're underestimating the amount of disabled people. And we don't know exactly by how much. It'd be 42% per their content test in this initial survey, but you don't know how much. This is going to vary year by year. So there was an immediate outcry. I was one of the researchers who led this to say, well, y'all can't just make this shift like this without any feedback from the disability community. And as a result, in February of this past year, the Census Bureau halted their plans. We got 12,000 people to give feedback on the Federal Register site to say, no, you can't just make this change. You have not engaged the U.S. disability community, policy planners, researchers, in order to understand the impact that it's going to have. And these are things you might be interested in going forward in September of this year. And I've forwarded my slides to Leslie. If you're wanting these links, she can share the slides with you, because each one of these highlighted, you can get to the link for these meetings. In September of this coming year, there'll be a stakeholder meeting with representatives from the disability community. So the Census Bureau will be engaging with the U.S. disability community to get feedback on what needs to be done in order to make disability measurement more inclusive and equitable. And then my group, the Disability Health Equity Research Network, is having a conference in September as well, September, I think, 17th, where Rob Santos, the director of the census, will be presenting, as well as members of this last group I've got here, the disability data. interagency working group, which consists of 35 federal agencies that have come together to try to think about how do we need to best capture disability in federal surveys, and also some leading researchers on the topic. So beyond the presentation today, if you want to keep up with this topic or attend any of these, like I said, these links are in the slides that I sent to Leslie. What I'm going to present to you is a roadmap that the group that I work with put out. So it's right now there's 13 of us, 13 or 14. It's a disability data equity research working group. I think out of the 14, 10 of us have some type of disability, and then 4 allied folks. And we are across universities here at Syracuse, Johns Hopkins, Brown, Kansas, and then a couple of institutes, Urban Institute and American Association of People with Disability. And so what we did is came together and said, okay, we're at this kind of shifting point where something's going to change. I mean, our hope is that we don't go backwards and shift from what was been the ACS 6 questions to the Washington group questions, but there's going to be a shift. Something's going to change. And these are the 3 things that we're pushing for, the way that we think things should go, the roadmap that we've set forth of what we think should be done in order to make disability measurement in national surveys more inclusive of as many disabled people as possible, but also more equitable. So we laid this out into 3 goals. There's an immediate goal, a midterm goal, and a long-term goal. And so the immediate goal that we set forth is that we need to continue using the American Community 6 disability questions, the first ones I showed you, the yes/no questions. And so specifically what we're saying is that there's 2 sets of questions being used. HHS has said the ACS 6 is the standard, so don't change. Don't be changing to the Washington group questions. This is not something that HHS has approved, and it's not something, as you'll see here in a second, that is actually beneficial for estimating the size of the disabled population in the US. The reason for this is studies are consistently demonstrating that the Washington group questions underperform in their ability to capture disability status. And let me show you a few of these surveys. So the first one was Jean Hall and her group at University of Kansas put out a paper. What was this? I think a year or 2 ago. Jean administers the National Survey of Health and Disability, and it is a survey of over 2,000 disabled adults in the US, age 18 to 64. And she puts this out every year. I think she's since expanded this to be 18 and over, all the way to age 85 or 90. And so this study, she had used data from the 2019 through 2020 wave. So what you've got here, so our baseline that we're looking at is everybody in the survey is disabled in some way or not. She's got screening questions that opt people into the survey that indicate they've got some type of disability. And so among the people who took Jean's survey in 2019 through 2020, what she did in this year, she fielded both the full ACS 6 questions and the full Washington group questions. So everybody in this survey is disabled. The ACS 6 questions captured 80.5% of these disabled people in the survey. And here's where you see the underperformance. So this is, neither one of these rates are good. So let's admit this up front. 80.5% of disabled people is not accurate. I mean, 100% of people should have been captured as disabled. So we'll get to this in the third point I'm going to make about the ACS 6. But for now, let's focus just on the comparison between the 2. So the ACS 6 questions captured 80.5%. The Washington group questions only captured 56.9%. And so a substantial undercount, more so in the Washington group questions than the ACS 6. All right, the next one is a paper that I put out with some of my colleagues where we went back to the National Health Interview Survey. This is the survey that I said had changed from fielding ACS 6 prior to 2019 to only Washington group in 2019. The benefit, though, of this survey is that for a couple of years, they fielded both questions. This was a time period in which they were flirting with the idea of making this shift in the disability questions. And so for 2011 and 2012, they fielded both to those 18 and over. So it gives us a chance to kind of compare their performance. So what we did here is we took a different baseline. Our baseline in this one is the 4,824 adults who reported they're disabled using the ACS-6 questions. So in those yes, no questions, they said, yes, I've got one of these 6 disabilities. So what we then tried to understand is among these people who report an ACS-6 disability, what percent actually report the same using the Washington Group questions that has that scaled response. And it was less than half. So only 42.9% of people who reported an ACS-6 disability were captured by the Washington Group questions. The thing that was really interesting that we found is it seems like the Washington Group questions are best at capturing number of disabilities. So the rate of capture was 29% if the respondent only reported one disability. So they said, I just have a vision disability. For people who reported 2 disabilities, so vision and mobility, or mobility and self-care, it was a 55% capture rate. And it jumped up to 75.2% for 3 or more disabilities. And so what we found here is this really underwhelming rate of capture in the Washington Group questions, but one that got better if you had more disabilities. Now, this is not the intent of the Washington Group questions. They're just supposed to be measuring disability, not number of disabilities, but it's what actually is going on in the data in the National Health Interview Survey. And then one more. This one is actually under review right now, so I don't have a link for it up. Once again, we went back to the National Health Interview Survey, but we took a different tact. So from 2010 through 2018, the National Health Interview Survey also included another set of impairment-related questions. And it's a 2-part set. Your first asked whether you have an activity limitation, and it's an activity limitation in activities of daily living, instrumental activities of daily living, work activity limitations, school or school activity limitations, and then they've got just a general, do you have any other activity limitations? And then if you report having an activity limitation, it asks you, what's the causal condition? Is it due to a hearing problem or a vision problem? Or there's a list of 35 causal conditions. And so what I'm going to show you here, so these are to define what you've got here are ADA defined disabilities, because an ADA disability is defined as an activity a condition, causal condition that results in activity limitation. And so for the 2 most common activity limitations that are captured in both the Washington Group and the ACS-6 survey, we tried to see, okay, among those who stated they have an ADA defined disability, what's the capture rate in these 2 sets of questions? And here you see the difference again. For a hearing disability, it's 94.4% using the ACS-6. In the Washington Group, it drops down to 67.5. And a similar drop, visual disability, 91.4 to 65.5. So what we take from these 3 studies is there's obvious evidence that the Washington Group questions are underperforming. They don't do as well in capturing disabled people. And as a result, they make it look like there are fewer disabled people in the US population than there actually are. So again, what we're suggesting to the Census Bureau and other federal partners, immediate goal, don't make any changes. Stick with the ACS-6 questions. We would actually even say further, switch back to using the ACS-6 in the surveys you have already made the change, but don't be making any more changes, because doing so will severely undercount the disabled population. But then we need to move to the mid-range, because as you saw earlier, the ACS-6 questions themselves underperform. Going back to this study by Gene Hall. Where is this one by Gene? This is it? Yeah. Like I said, 80.5% is not a good capture rate. Washington Group is worse, but the ACS-6 questions themselves are not sufficient. They're not doing a good job capturing everybody that's disabled. And so in this study that I reported to you just in the last slides on hearing and visual disability, we took some other disabilities, because the concern has been from the beginning, if you look at those 6 ACS-6 questions, vision, hearing, cognition, mobility, self-care, and IADLs. I mean, you think about what's missing: intellectual and developmental disability, mental health disability, physical health disability. And this has been a critique of the ACS 6 questions from the beginning, is they're only asking functional limitation questions around certain types of disability. And typically they're more physical related disabilities, physical or sensory. They're not capturing some of these other mental cognitive related disabilities or physical health disabilities. So what we did in this study, the one that's under review right now, is we're looking at some of these other disability statuses that the ACS 6 questions, the ones that we're saying to census, keep them, but how are they doing with these other disabilities? And as you saw with vision and hearing, let's keep this in mind, the rate of capture for hearing and visual disability in the ACS 6 is around 90 to 94%. So these are disabilities that are named in the ACS 6, so they're capturing a higher rate. But if you get to these disability statuses, there's the reminder, yeah. If you get to these disability statuses that don't have prompts in the ACS 6 questions or Washington groups directly related to the disability, you see this lower rate. For people who have a birth defect, it's down to 82.5% in the ACS 6 and 51% in the Washington group. Intellectual disability, 89% in the ACS, 51% in the Washington group. Other types of developmental disabilities, such as cerebral palsy, 83%. So we've gone lower even in the ACS 6, 52% in the Washington group. Mental health disability goes down to 80, 46 in the Washington group. Cancer, and this is cancer with that's causing some type of activity limitation. So it's an ADA defined disability, goes down to 74% capture rate in the ACS 6, 47% in the Washington group. Diabetes 81 and 46. So what we see is neither one of these questions is doing a good question sets is doing a good job capturing these limitations that are not directly named in the prompts. Again, the ACS 6 outperforms the Washington group, but neither does well. So what we're saying is short-term goal, keep the ACS 6, but the mid-range goal is you need to add question prompts. What the HHS guidance states is that you can add additional questions to the ACS 6 survey questions that are already there. And they've done this in Oregon. Marjorie McGee, you might know Marjorie, with the race, ethnicity, language, and disability demographic data collection standards. And again, if you get these slides, you can click on the link. So here are the questions that Marjorie added in Oregon to try to supplement the ACS 6 and do a better job of capturing more disabled people. Do you have serious difficulty learning how to do things? Most people your age can learn. And Marjorie found that this does a better job of capturing people who have an intellectual or learning disability. Using your customary language, do you have serious difficulty communicating? So a communication disability. Do you have serious difficulty with the following: mood, intense feelings, controlling your behavior, or experiencing delusions or hallucinations? And she said this does a good job of capturing mental health disability. And like I said, in the state of Oregon, they've already started using these questions and they're finding higher capture rates using the ACS 6 plus the supplemented 3. And then Marjorie does not include a question about physical health disability, but there is a survey in Canada, the Canadian Disability Participation Project, that has offered one that says, do you have a long-term physical health problem or condition that affects your participation in daily activities? So again, our short-range goal that we've offered the Census Bureau is keep what you got, keep the ACS 6. This is what HHS says we should be using. The mid-range goal is to supplement these questions so that we do a better job of capturing people who have intellectual and developmental disabilities, mental health disabilities, physical health disabilities, and communication disabilities. That way, we're hoping that that rate of capture will expand beyond 80, 90% to get to close to 99 or 100%. And then for the long-range goal, and this, I mean, long range, we're talking 10, 15 years. What we're contending, and it'll be interesting to see what you all think about this, is it's time to move beyond these deficit-based models and deficit-based ways of measuring disability. So if you think about either the ACS 6 or the Washington group questions, and I'm critiquing both here, they're both based upon trying to understand what it is disabled people can't do. They can't see well, they can't hear well, they can't walk well, things like that. And these are important things that we need to be measuring. We need to know the functional limitation status of disabled people. That's helpful information for health providers, but even for local communities to know how severe someone's limitations are. What we're contending, though, and what we know from talking to disabled people and other evidence, is not all disabled people have functional limitations. So if you think of someone with some type of like facial paralysis, I've got a good friend in Oregon, professor there, who's got facial paralysis, and she'll tell you, I don't have any functional limitations. It doesn't affect my ability to see or to do daily activities or to walk or anything like that. But I definitely experience a whole lot of ableism and a whole lot of marginalization, and everybody around me knows that I'm disabled. So it's a distinct disability. It's a disability that is named by the Americans with Disabilities Act, yet is not going to be captured with functional limitation questions. Think about someone with multiple sclerosis whose functional limitations are episodic. So yes, you survey them during a time period in which they're having a flare up and they're having difficulty walking. They're going to report that functional limitation. But say that you catch them during a time period where they're not having a big flare up and things are going pretty well, and they've not gotten to the point where their limitations are permanent, they're only during a flare up. They might respond during that moment that they don't have any limitations. Be the same with someone who's got like arthritis or other episodic conditions may be related to their immune system. According to the Americans with Disabilities Act, these are disabled people. The ADAAA, the amendments to the American Disabilities Act, says that episodic conditions that in the midst of an episode are disabling are disabilities, whether the person is in the midst of an episode or not. This is not captured when we use these deficit-based functional limitation questions. And so what we're trying to argue here is that to use deficit-based models necessarily undercounts the disability community because it does not capture people who have disabilities that don't have these functional limitations. We're not saying to quit using things like the American Community 6 questions, or even if someone wanted to, the Washington Group questions. I know folks in the medical community really want a scale-based measure. They say it's really important to not just know that someone has a functional limitation, but they need to know how severe it is, whether someone cannot do the activity at all or has just limited difficulty doing the activity. That matters for medical planners, for hospitals, for communities to know, okay, what's the population that we're serving? What type of limitations might they have? And so what we're arguing here is you don't need to quit using things like the ACS6. In fact, I would not even be against someone, using a scale-based measure for functional limitation. I would really question using the Washington Group scale because, like I said, that sum category, SOME, sum, seems to be difficult around the globe for people to understand exactly what's going on there. And so if we shift away from using these deficit-based models, you could continue using the ones that are already in place. And I would think you probably even should because it could give you continuity of measures. But we've got to move beyond doing that. And the question would be, what would that look like? So the current strategy that's being batted around now is a CN-STAT study. So who is that? I'm just blanked. The National Academies of Sciences, Engineering and Medicine do these CN-STAT studies. It's their statistical group, and they're really, really favored by the U.S. Census Bureau because they give you an overview of all the evidence in the field in order to understand what do we have in measurements and where do we need to go. You know, the challenge and what we've really been pushing back on is that to date, none of these measures, be the ACS6 questions or the Washington questions, have been created with interaction with the U.S. disability community. They've been created by small working groups or research groups. And based on the evidence that we see from minutes, that were not inclusive of any disabled people. and did not talk to disabled people in the US. They did incorporate, the Washington group did talk to some disabled people in other countries, but nobody in the US. And so what we're saying is that no matter which direction forward, that it's going to have to involve robust interaction with the disability community in the US so that they can offer feedback on where we need to go. I think the question that's on the board is, if we move away from a deficit-based model, then what are we measuring? I mean, and that's what you hear a lot from federal partners is okay, well, let's not use these functional limitation questions to decide who is and is not disabled. Then what is disability? What does it mean? And some folks are arguing that we need a new model. Let me just turn these slides off here because I'm just talking now. Some people say that we need a new model for doing so. And I think the question becomes whether that's actually the right strategy. Or have we gotten to the point where the models are what is getting in our way in the measurement? Because if we say, okay, I mean, the Washington group will tell you, so will ACS 6, well, we're doing the social model. Because let's think about the social model. The social model says that what disables us is society. It's the social structures that create barriers that keep us from participating. That's what makes us disabled. And that what's going on in your body is your impairment. That's your physiology. And so what these ACS 6 questions and the Washington group questions apparently measure is the social model. We're measuring the impairment. And then based on knowing whether someone's impaired, you can decide how disabled they are by society. So in a way, you're not even playing with disability, you're just measuring the impairment level. You go to a medical model. This is what's used in like the ICD-10. Okay, it's just straight up diagnosis. Do you have Down syndrome? Do you have cerebral palsy? Do you have spina bifida? Do you have a spinal cord injury? So if we move away from that, as not that we get rid of those measurements, but we move away from using those to define disability, what do we use? What do we use for that person who's got facial paralysis? It doesn't have any functional limitations. What do we use for the person who's got multiple sclerosis but is not in the midst of a flare-up? And how do we define disability? And I think the pull here, I don't know if y'all have read Elizabeth Barnes. It's somebody I would suggest. She's got a really good book called The Minority Body that she published a few years ago, and then a sequel that she calls Health Problems. And what she argues, and it goes along with what Rosemarie Garland Thompson argued back in the late 90s, is that the social model really has abandoned the disabled body. Because what the social model says is, okay, disability is due to the social structure, but the impairment, the body, is still owned by the medical community. And so the social model kind of cedes the body to medicine. And that's what these measures have done. They said, okay, it's our body. We'll measure it through functional limitations. We own the body. We'll measure it through medical diagnoses. And so what Barnes is saying is we've got to move to trying to relocate disability back into the body and the mind, and saying something's going on here that we need to capture, be it in the way that people are, the normative standards that people are supposed to fulfill in the way their bodies functions and the way their bodies look and how they operate in society. One interesting thing that has occurred just in the past 3 months is the city of Boston has said, okay, let's try to do this. We're going to quit measuring functional limitations. So the city of Boston has decided that across the entire city, all services operated by the city, they will no longer ask whether you have a disability or whether you have a functional limitation. Instead, they're going to ask your accessibility needs. What would you need in order to fully participate? And so they get into specifics. Do you need transportation? Do you need, ramps? Do you need communication devices? And so they're saying that let's move away from measuring disability at all. Let's just measure the accessibility that someone needs. I mean, the positive side to that is you can reach some people who might be disabled who would not report as such. But the downside is, what if you've got a disabled person who can walk up the stairs fine, or has learned to navigate with limited sight or whatever, and doesn't have accessibility needs? I think the other big question you get into is, what about folks like veterans? I used to work in the VA, and I knew many disabled veterans who would never, a day of their life, tell you that they're disabled. It's not language they use. They'll tell you they're a wounded warrior. They'll tell you that they got injured in battle, but don't call them disabled. Actually knew a guy who had a disability parking tag, but he would hide it. And he would park the car in a disability space and get out of the car and have his wife or his daughter put the tag up because he did not want to touch it. That's how against he was, how much he was against saying that I'm disabled. What are you going to do in a survey for someone? So what I'm getting at here is this: the solution can't be just asking people, are you disabled? Because not everybody who's disabled has a disability identity. So if it's not going to be functional limitations, if it's not going to be medical diagnoses, if we don't use disability identity, what do we use? The group out in Kansas, Gene Hall's group that fields the National Survey on Health and Disability, they're saying we need a mashup question. We need to ask people, do you have a disability, an impairment, long-term health? And so they put in together like 5 or 6 different factors. And then they follow up, do you have accessibility needs? Do you have to use technology to communicate? And questions all about accessibility. And then they're going to put in another set of questions about accommodation. And so what they're arguing is you're going to have to do 3 sets of questions and hit this thing from different directions in order to capture everybody. Now, when you convey something like this to the Census Bureau, they're like, no, we want 1 or 2 questions in limited space in our survey. And that's all we're going to put here. So that's where I wish I could give you answers on this. I don't have them right now. This is the debate that's going on. This is what will be talked about at the September convening, as well as our conference that we're hosting the census director. Something's going to shift over the next 3 or 4 years in how we measure disability in this country. We could go to the Washington group questions. And if we do, we're just going to have to accept that we're going to undercount the disability population by over half. We could stick with the ACS 6, or we could go a new direction. And so I think it's ripe for debate. It's ripe for input. And I look forward to hearing what y'all might think about it.
Very interesting. Okay, so I just attached your slides. Now that you've gone through those, they should be in the chat as well as a few links. But the question's been put out there. What do people think of it? What questions do you
Oh,
have?
I have so many thoughts. First off, I just want to thank you for your time. This stuff, you got my fire lit here. I often find myself pretty perturbed by how narrowly we define disability, especially around a hyper medicalized way, and very squarely in sort of the interiority of the body mind. And I'm like, it's everywhere. It's complex. I do wonder though, to your question that you sort of posed to us of like, well, how do you define it? I do wonder if maybe one route in some ways is, it sounds like I'm very interested in this, what Boston seems to be doing around like building it around accessibility. But what if accessibility is just defined a little broader than we usually do? Because you talk about, for example, your peer who has facial paralysis but doesn't have any sort of doesn't necessarily have what we consider functional problems. But I even wonder, like, is there a way to conceptualize the ableism that she sort of encounters on a day-to-day as an access needs problem? And if you there's maybe a risk there where you get to a point where you maybe overly, what point do you eventually reach just like poverty is disability? But like, that might be true for what it's worth. But like, does just broadening the question of what accessibility is, it gets to the point where it encompasses both traditional conceptions of deficit and these more sort of social questions of the complex interaction between body, mind, and structure around it.
Yeah, and you brought up ableism, and that's a really good point. I mean, some folks have argued that that's what we should be measuring more so than disability status. In fact, NIA put a NOFO out last year. It's been, I think, awarded to 4 or 5 groups to start trying to create measures of ableism. I think we need to have ableism measured and the discrimination people experience. I think the trick's going to be how do we meet the needs of all groups?
Right.
Because
Sorry.
no, go ahead.
It just seems to me like the central tension you're proposing is that like we need concrete metrics to sort of demonstrate need, right? That's the very practical material reality of the thing. But that seems to be in direct contrast and tension to like the very act of categorizing and sort of
Exactly.
metricing it's sort of runs away from the truth of the thing.
Yeah, and I think that's, I think any Bowker and Starr's they have the great book on classification, and Olison's done Olison, and then, if you think about Teferi and Bonilla-Zelia, Silva's idea on kind of white logic, white methods. I mean, we see with this with race is anytime we classify any characteristic, we lose important things about people. And that's just part of the process. But like you just said, we have to do it, or else we lose the ability to say this group needs more. And within this community, this population needs more assistance. And so how do we split that? How do we maintain enough of who people are, count as many people as possible, but do it in a way that's not so constrictive? And I mean, I've got ideas. I'm actually writing a book on this right now, so I'll tell you more next year. How do we define disability in such a way that it captures what's actually going on, that's inclusive of everybody or as many people as possible, but can be measured? Yeah, it's a challenge.
Well, and it's really interesting because the psychometrics of any other item rarely, other than demographics, and you've made that argument, and Cortland, you were saying this too, we hardly ever apply the same definition across different situations. So psychometrically, not to do that.
Right.
And so that's what's making it really difficult. I mean, can you also talk, I mean, well, maybe this group that you're talking to, or these groups already know this, but we're going to do it anyway. And so you're looking for consistency, but can you still factor in the need to consider the situation and to look at the psychometrics of the item? I mean, that's what you're doing in the
Yeah.
research, right? And telling them those psychometrics are not that great.
Right. I think you have to, and you've got to take anything you create through. That's the whole problem. Like we were talking about content validity testing that the census is doing. And so we're talking to them about, well, how do you do your content validity testing on the disability questions? And we're assuming that you gather together a, heterogeneous group of disabled people representative of the population. And they're like, no, we just get some people together and we assume some of them are going to be disabled. It's like, wait. Do you have any idea whether you've included people with intellectual and developmental disabilities or with, health? Well, just whoever shows up that's disabled, we talk to them about the questions, and it's like, okay, how can we say any of this is valid,
Right.
if with the how we've created these measures? Yeah, I think the other thing, is because I think about, I mean, I'm disabled myself, multiply disabled, and I think about, sometimes to me my disability is medical. Like Leslie, I was talking to you about, I had brain surgery this last year. By God, yeah, my disability was medical, and you better do something about it medically. Sometimes it's an identity issue. When I'm going into work and asking for accommodations, it's becomes an identity issue. It's a minority issue, or you all need to give me these accommodations so I keep doing my job. Sometimes it is about level of functional limitation. How much sight have I lost? How much do I have left? How do we capture all of that? And then also the people who don't have any of that, but are still disabled. Yeah, it's just, I don't know. I don't know what the answer is. I don't know if there is going to be a good answer. Maybe someone here will figure it out for us.
Well, you have ideas. The book is for sure.
The book is just a lot of chance to put what you think down and hope it comes out to a good place. Yeah.
Mm-hmm. Mm-hmm. And definitely for the funding piece, you can't let that go too long.
Yeah. I mean, I personally think, and I go back to what Rosemarie Garland Thompson, when she was a literary scholar, and so you're not going to be able to measure this fully, but she says that, disability is nonconformity incarnate. And Cortland, it goes to what you're talking about. I mean, in a lot of ways, to me, what disability is broadly is it's nonconformity to ableism. It's okay, you've got these ableist physical and mental normative standards of what our bodies should be, and we don't conform.
And even then, it's complicated. Sorry, not to get too in the weeds here, but I guess that's what we're here to do. But even then, it's complicated where I feel like there is even a question of like, when is that othering coming from a place of like sort of internal authenticity? And when is it being like forcibly and sort of non-consently placed onto somebody? I think about this from like a mental health perspective, right? Where how many people are, maybe they would not self-identify as disabled, but boy, has the state like sort of like placed disability onto them. They sort of rob them of competency, things of this nature. And so that kind of even gets complicated around, this question of, you know, when is otherness a sort of like thing we hold sacred and find affinity in, and when is this otherness like, to use the mental health framework, for example, like an over pathologizing of what should be reasonable reactions to things.
Oh, yeah. I don't know if y'all have read it yet. Sammy Schlock's Black Disability
Oh, I
Politics.
love her.
Yeah, and that whole idea that, for the American Black community, disability is not a good word. It's a word of white supremacist. And you think about histories of forced sterilization where, yeah, you were sterilized under rules about disability, but it's because you were a Black woman. And so, why would anybody in that community ever want to identify as disabled? So if we get into the intersectionalities, yeah, I don't know. I don't know what the answer is going to be, but I do know.
And how does one even, sorry, and how does one even like have the time to conceptualize and wrestle with a disabled identity when their access needs very well might be coming from the overt effects of racism in the first place? Like,
Exactly.
Mm-hmm.
And then to the flip side, if you're in a low income situation, you're using a wheelchair, the reality is in your mind, the way that your situation and social structure is set up, your functional limitation is the main problem. And so there are some situations in which these questions are capturing really what's going on, but there are others that are not. So yeah, this is the dilemma. But we're going to have to find a solution because Census Bureau is saying we've got to measure this. It's going to be a compromise. I just know it is. There's no way that because we don't have perfect questions. So what is the compromise? You've seen what we're suggesting, but I would invite you all to, get on that link for the census convening for our conference coming up and participate, come to hear what's going on. We need more people to be lending their voices because this is the time period in which the census is willing to hear feedback from the U.S. disability community and allies. And so it's a chance to kind of participate in the process and see where we end up.
I think this process is a good model for state level discussions, because pick a condition, pick a disability area, someone sets a definition that's determining the state benefits that you're going to receive.
Yes.
Everything that we're talking about here applies to that determination, right? And so there's lessons learned from the process. Just that, let alone what census ends up doing. But wow, how interesting.
Yeah.
Well, so everyone has those, just to reiterate, everyone has those links in the slides. You can download them from the chat. I can circulate them as well. Just let me know. But we're close to 3 o'clock. This was a great discussion. Thanks for including us, and we will definitely circulate that and try to participate in those discussions.
Yeah, thanks for having me. And I do hope y'all will join in and let your voices be heard because like I said, this is a time where you can really make a difference.
Mhm.
And because something's going to give.
Absolutely. And for those on here, I know that you have advisory groups, individuals with lived experiences. Please share. Feel free to share those for that very purpose. Okay. Thank you, Dr. Landis. We appreciate your time.
All right. Thank you all and have a happy and fun semester.
Same. Take
Okay.
care.